Good morning, good afternoon, and hello everywhere you are. In case you're in a different time zone that doesn't abide with the good morning and afternoon greetings, this is George Dengas from Mount Sinai Heart, and this is the endovascular peripheral vascular intervention session live webcast. As you always know, our communication can be enhanced if you use the email info@peripheralvascularinterventions.org, peripheralvascularinterventions.org, and send us questions or comments throughout the case. You can always go back to our website, www.peripheralvascularinterventions.org, in order to see all the archived cases, including last month's carotid intervention case. And you could also view the same website, and every month we also post an educational video at the site, and you can also view that. Today we have a special setup in that in addition to myself, we have a second moderator, Dr. Jeffrey Olin, Chief of Vascular Medicine at Mount Sinai Heart, who is going to alternate the moderator position with me. He's going to start up in the room, and before further delay, I'd like to pass it on to the cath lab to meet Dr. Krishna and Dr. Wiley, as well as Dr. Olin in a little bit.
Good morning, George. Good morning, everyone. We're really excited, obviously, to have Dr. Jeff Olin here, who's fibromuscular dysplasia. And our patient here is really an example of this disease and how difficult it can be to treat. Just want to remind everybody that Dr. Olin is going to be giving a lecture on fibromuscular dysplasia after our case is done, which he's going to share some of his expertise with us in only in terms of diagnosis, but also in terms of management. What we hope to accomplish today is to show you a multi-imaging modality approach to the disease process, which I think will really help patients in combating this disease. So I'd like to introduce my team. I've got Dr. Jose Wiley right over there, who's going to give you the history in a second. I've got Lascano, our nurse practitioner, Elizabeth, our nurse, Pablo and Ricky, our technicians, as well as our interventional fellow, Pratap. So with further ado, Dr. Wiley, you want to give us the history?
Sure. Good morning, everyone. This is a 19-year-old young man with a history of right renal fibromuscular dysplasia. Had a prior PTA to the right renal artery in 2009, and has uncontrolled blood pressure on 3 antihypertensive medications, including a diuretic, who recently had a renal duplex showing elevated peak systolic and diastolic velocities at 425 and 194 centimeters per second, respectively, on the right renal artery associated with turbulence and tortuosity consistent with fibromuscular dysplasia.
Has been treated in the past at an outside hospital and has had increasing episodes of high blood pressure with real just spikes and valleys that really give him his symptomatology being headaches, neck pain, and as well as shoulder pain. Obviously, he's a young man on multiple medications, and so we had brought him in for a diagnostic angiogram earlier, but we'll go over that. But now I'm going to throw it out outside to Dr. Olin to go over the ultrasound, which was done here at Sinai. Jeff?
The ultrasound, the renal artery ultrasound in FMD is a little bit different than atherosclerosis. What you can see here with my pointer is the aorta, and we've laid the entire renal artery out, and the kidney is right here. So whereas atherosclerosis occurs in this location, FMD occurs in the mid and distal part of the renal artery, and actually you can see the turbulence to flow. And this is exactly where the velocity elevation will be in this particular condition. This is an example of the left renal artery, and again, you'll see from the angiogram that there's a focal stenosis in this particular area. And we have very high velocity elevations in both renal arteries. You can see here a lot of turbulence. So we're out in the right distal renal artery, right near a branch, and we have peak systolic velocities of 400 with end diastolic velocities of 200. This indicates it's a very severe stenosis, and if you don't look in this area, then you will not make the diagnosis of FMD. In other words, if you don't lay out the mid and distal renal artery, you won't see this particular disease because it does not occur at the origin. PK?
Thank you. Oops, my volume is very high. Sorry about that. Thank you so much, Jeff. I want to just go over the angiogram and how and what we decided to do on this young man. So what we obviously had a diagnostic angiogram prior, and I want to go ahead and show you what we had done. So the way to engage a renal artery is to actually use what's called as a no-touch technique, and the no-touch technique is done because obviously the progression of the disease in normal atherosclerotic kidneys, and this doesn't so much apply to FMD here, but in general in how to do a renal angiogram, I think it's extremely important. Cardiologists, radiologists have a lot of respect for this particular process of this atherosclerotic a plaque extending into the kidney, and cardiologists tend to go with guides and just shove guides into the kidneys. The danger of just shoving a guide or into the kidney is that you can actually avulse the plaque in the aorta and actually shut down the kidney. Now, obviously, that's not the case in this particular patient because he's 19, doesn't really have much. He has some plaque, but that's not the pathophysiology of this particular disease. So what at this particular stage, I wanted to demonstrate here how you actually engage with the no-touch technique. Now, the no-touch technique has been pioneered by Dr. Sauce and multiple other people who have been doing renal intervention much longer than I have, but clearly it was really time-tested and true. And so what you do here is you have a guide, which is here. In this case, we decided to go with a PK1, which is a Medtronic guide, and then you have an 035 wire up in the aorta. So the 035 wire up in the aorta actually pushes the tip of the guide, pointing it upward away from the ostium and preventing scraping of the ostium. So at that stage, what you do is you actually introduce your 014 wire into the guide and get it to the tip of the guide. And then as you pull down your wire and you get into the floppy tip of the wire, what happens is that the guide will slowly start pointing towards the kidney. Now, this is a great example of how we're engaging. You can see here that this guide is not touching the renal artery ostium, okay? Which is extremely important, not so much in this particular case, but in terms of how you're going to do it in an atherosclerotic kidney, which I think is more common than FMD in terms of a general cardiologist doing interventions. So therefore, if you have the right indication, do a kidney angiogram and obviously fix the kidney, you do not want to have a procedural complication while we're engaged in the guide. It's been well documented in multiple journals about closing the kidney, patient going to emergency surgery, so on and so forth. So at this stage, what we've done is we've actually engaged the guide, engaged the wire into the renal artery. So we have one wire floating in the aorta, supporting the guide away from the ostium of the kidney. You have one wire actually going into the kidney. Now, what you do, the next step is you just pull the 035 wire out of the aorta and let it flop into the kidney. And you can see here, we just showed you the next step, which is obviously the 035 wire is out, and then you have the 014 wire in. So at this particular stage, what we decided to do was a pressure wire on this side and the other side. If you can show us the pressure wire, because we did have elevated velocities, and we'll speak to Jeff on this. If you see the pressure wire, if you can show us the screen here, on the left side, the gradient was only 8. So on the left side, angiographically, we didn't see much, and here's the left side pressure wire with the gradient of 8 with the wire distally, as you can see.
This was a gradient, a resting gradient, PK.
Well, yeah, I think in renal intervention, our protocol has always been really resting gradients. I mean, we have not done any vasodilator issues, and we can again discuss with Jeff on this particular kidney whether we should. Obviously, Chris White has done renal FFR work at Ochsner where I trained, and so we do have some experience with stuff like that. But I just wanted to illustrate what we've done with the pressure wire here. We have a resting gradient of 8, and angiographically, I'm going to show you angiographically, which is a more selective picture, again shows that in that mid-distal area, there's really no, FMD or no significant stenosis that we see angiographically.
Yeah, that's very clear. There's about a 30 to 50%
right,
stenosis.
But George,
I'm surprised that they found velocities. I'd like to know what were those velocities and then what was the ratios and all that.
Sure, we'll get to that in a second. Now, angiographically, obviously, this is an atypical looking FMD because you would expect a string of beads appearance. You would expect, a different type of angiographic experience. But let me just go right to the next before we get Jeff's thoughts. We went to the right side. We did the same thing. Obviously, we did not show you how we did it, but we got the same type of procedure. We went ahead and then we got a wire across which is our pressure wire. And now we're engaged with the guide, and we took a picture. And I want to show you our pressure here. And if you can show us the monitor with the pressure, please. And again, now you see a resting gradient around 35 millimeters at this particular area of the kidney, which again correlates very, very highly with what we have in ultrasound.
Which is a much tighter stenosis.
And also angiographically, it's also reflective. Now, I mean, obviously, you don't want to get fooled by angiographic lies, as we know with FMD. It's very difficult to know when to stop, when to continue. So here we have some physiologic evidence as well as Jeff's ultrasound evidence of true FMD. Now, important, obviously, this case, we're doing a renal case. We've given heparin. We've gotten 2 ACTs. One was 298. The second one is now 288. So I'm comfortable leaving the wire there. I flushed my guide. I'm ready to go. So while Jeff gives us his thoughts, we're going to go ahead and IVUS this to just look at it under IVUS. So can we get the IVUS ready, please?
Different than the standard FMD. As you noted, this is not the string of beads type of FMD. This is intimal fibroplasia. So this is, the angiographic picture of this is a tubular stenosis, or a focal concentric area of stenosis. And I think it's obvious to everyone that on the right side it's quite severe. On the left side it doesn't look so bad, but it's intimal fibroplasia on the left side as well. I think you'll see that on IVUS. And while the gradient was only 8 millimeters of mercury, the peak systolic velocities on duplex, a very technically good duplex scan, was markedly elevated. So I think that it probably is a hemodynamically significant stenosis, and I would go ahead and treat that lesion as well.
Now, Jeff, may I ask you, how do we distinguish an intima from a medial fibroplasia, for example?
Okay, so the terminology for all this is going to be changing. An American Heart paper is going to be coming out very soon on the state of the science of this, but this is going to be called in the future focal FMD, and medial fibroplasia is going to be called multifocal. But the way you differentiate is in medial fibroplasia, there's the classic string of beads, multiple areas of dilatation and constriction, which you can see very well on IVUS. Intimal fibroplasia has two appearances. One is this long tubular stenosis, which you see in this particular case, and the other is a focal band-like constriction, where it's almost like you tie a string around the artery and constrict it. So those two appearances are characteristic of intimal fibroplasia. It's more common in men, it's more common in young men, and it can occur in the renal arteries, it can occur in the carotid or vertebral arteries as well.
Jeff, if I can just interrupt, because we've got the IVUS in the vessel, and I think you're going to find findings interesting. If you go live, you can see the IVUS is likely distal to the lesion. And I want you to go on IVUS here, show us our IVUS, and George, you can also comment with us. As you can see the IVUS, can you make the IVUS bigger, guys, and the angiogram smaller? You can see clearly no atherosclerosis at all. And I'm going to pull back very, very gently, and I'm going to do it both on the fluoro and under IVUS, so Dr. Wiley and I can see here. You can see as we're coming back, it really looks very, very nice. And now you can see, you're going to see a focal sort of narrowing coming up very, very soon, right in this particular area, which you can see right here. And it's going to get even tighter and pretty much gets around catheter at this particular area, which correlates with that particular area on the angiogram. And then when you pull back further, you're going to see that it's going to disappear, and the vessel go back to normal.
So PK, if this was medial fibroplasia, what you would see is you'd see multiple areas of constriction and dilatation, and you'd actually see the webs present in medial fibroplasia.
Can you guys go over the IVUS again, Jeff? Or George, if you can just play that again one more time.
Yeah.
I just want the audience to really see that.
First of all, we can see here in the distal part, in the bifurcation, that you see the two lumens there, and there is essentially a normal artery with a minimal thickening of the intima, and now you can see the entire vessel becomes smaller in a way that still you don't have any atherosclerosis. You just have a constriction of the vessel, a negative remodeling, one could say, by the pure IVUS terms, and then again you have a expansion of the vessel. You see no plaque whatsoever in this vessel.
Now I just took an angiogram, George, so for Jeff and you to look at. So you can see here that while they're measuring for us to balloon this, you know, we've got a post-angio. Again, you always want to make sure you don't have any spasm, you don't have any, you know, perforation with your wire, all the good things that you want to look at. And if you remember our first angiography, we clearly saw the renal cortex to make sure that we see a pre and a post. These are good disciplines to follow while we're doing this. So now at this stage right now, you've got a focal band that's been done. And now what we want to do is we want to balloon this. So we want to balloon this, and our choice of balloon is going to be guided by our IVUS. I mean, I know I had a long conversation with Jeff about this patient to get his advice. And, you know, one of the things you'd like to do in these type of patients is not to have to stent. But obviously, there are times that you have to bite the bullet. And so what we're going to try to do is really go one-to-one with our balloon, try to go ahead and expand this lesion nicely, not oversized, try not to dissect. But more importantly, we also have a physiologic parameter ongoing while we're doing our intervention. So now we can clearly show what the pressure is as the balloon goes up, as the balloon goes down, what the pressure is pre and post. Then we can do an IVUS post to make sure that this patient, that we've broken those bands and make sure everything is okay. So we're getting a 6 millimeter reading. Is it distal or proximal to the vessel at 6? Both. So it's a 6-0 vessel, distal and proximal. And I'm going to, you know, this is one of those things, you know, whether we go one-to-one at 6 or do we go with a 5 millimeter balloon first to start and then go with a 6. I'm going to leave it up to, obviously, you, George, and Jose to advise me on this particular way.
Well, based on the IVUS, let's say, without offering any other opinion, this is a negative remodeling.
Right.
So going to a one-to-one to the proximal distal reference, I think we'll have some risk of rupturing the vessel. So I think a gradual inflation would be more advisable here. And, you know, I'd like to hear Jose and also Dr. Olin's approach, views on how low do we start with this process.
Just a 5015?
The vessel size exactly at that time, at that spot,
Ricky,
was around 2.5.
Yeah, George,
Three.
George, I agree with you. We could start with a 5. If the gradient comes down to what we're comfortable with, we should be done. If not, then it would be reasonable to go up to one-to-one.
Well, you know, I just want to interlude that, you know, I think this gentleman has had an intervention in the past which was not guided with what we're doing. And I think that, you know, he's here with us, you know, obviously to get a resolution to this. So, you know, I agree. I mean, I don't think you lose anything because you can only go forward rather than backward. So I think that what we can do here is start with a 5. Because I guess our risk of dissection is going to be a lot less with a 5 than it will be one-to-one with a 6. And as George pointed out, it's not an atherosclerotic process here where you have to worry about expanding the lesion, so on and so forth. So I think I am going to go with a 5 here, and then we'll follow the pressures. Jeff, any opinion?
PK, do we have any idea of what balloon they used in the previous angioplasty?
You know, we have the CATS report. They did a 4.0 in the last one and a 4.5.
Oh, very good. Then we'll have to do better than that.
Well,
there you go.
yeah, and you know, I guess I'm cheating here, but I do know that we do have other modalities here, and we have Dr. Olin. So I really feel that, you know, we're going to achieve the result that we want with this gentleman. I'm going here while Jeff comments on his thoughts. I'm just to tell everybody what I'm going to do interventionally. We're going with a 5 millimeter balloon. It's a 5015 renal balloon called a Viotrac by Abbott Vascular. And we're going to enter this very, very gingerly into the vessel.
Is this a non-compliant balloon, PK?
It is a semi-compliant balloon.
Yeah, very good.
And you can see here it's going to enter right now. And Jose is just going to give me a little squirt so I can see where it is. And I'm just wondering what Jeff's thoughts are on the balloon size.
It's an 8 millimeter length.
Hold that.
Or it doesn't, and if it doesn't, then you have to stent.
By the way, if Jeff want to join in the moderation room with in the central control over here, that'd be great.
Okay, you can see here, George, we're going to give a little dye here for Dr. Wiley, just to see where we want to be center on the balloon.
Yeah, so I think we are. That's very good.
I think we're just going to pull back just slightly, and we're going to go up here slowly.
So
Now, obviously, for those of you who have not done renal intervention,
Going up at 2.
you want to go up very, very slowly down. You can see how the wire slid forward. I mean, the balloon slid forward. So I'm going to go ahead, pull the balloon back a little. Go up now.
Slow 1.
Because there is intimal. There it is. Now you got it. You see it right in the middle now.
We're at
You
2.
controlled it, and now you're going to go up. Now you're going to watch for the patient for 3 or 4 things. One is pain, 2 is bradycardia,
6.
because these are all signs of impending rupture, okay? What are you at?
8.
8. So we're at 8 millimeters with a semi-compliant balloon, and I'm going to go up a little bit more.
We're at 10 now.
10. What is nominal, guys? 8. Okay, so 10 is nominal, and this is actually a nice, go to coronary, please. I just wanted to take a cine of this.
Yeah, this is a nice demonstration how resistant this lesion is.
Yes.
This band is very tight.
Right, down.
And just to say that, you know, the pathophysiology of this is you try to break into the bands that cause this constriction.
Right, so now rather than go up, give me a little die now, rather than go up very high, which may cause a little bit of a dissection, inject please. I just want to bring a thought up to the panel. One is, there's been a paper that's been published with the use of angioscope scoring balloon in these type of resistant lesions. You know, it's obviously a single case study, obviously it's not a trial or anything like that, but that's another option in these type of patients that we can go ahead and use to be able to break. Second is to go with a non-compliant balloon to try to break this rather than expand it. So now, just to tell you where we're at, you can see angiographically there's an improvement. Now I'm going to ask our team to go back on pressure wire and show me my pressure difference after the balloon angioplasty.
So PK, if I can make a comment here, the most common reason these things recur is that they're not treated appropriately the first time. So even though angiographically it may look much better, you need to do exactly what you're doing. You need to get pressure gradients and IVUS before and after. And this is the one type of FMD that you may need to stent. But the risk of doing that is if you still can't disrupt that band with the stent, then you have like a dumbbell-shaped stent, and that almost always fails.
But so Jeff, I mean, that's a great point, and I think it's very important that people understand that there is a role for stenting in FMD. I mean, here now, Jeff, physiologically, we've got the FFR, the pressure wire, which shows a gradient that dropped from 30 to 7. With just a 5 millimeter balloon. Now you did see, go minus please, go C minus, if you can show us the angiogram, you could see minus one more, yeah. So you can see here that there is still a waist, a bandage. Now Jeff, my question to you is, would you recommend we go with a cutting balloon, or would you recommend we go with a non-compliant balloon, or do you think it's important now to expand this lesion, break this band, versus saying, hey, you know, we've done our job, our pressures are now 7, or now actually it's 3, it's showing it's 3, it's actually come down, to say that, hey, we've done our job, we've reduced this to nothing, and we've cured this guy?
Yeah, I would definitely not stop here.
Yep.
If you stop here, the patient's going to be back with a recurrence.
Right.
I don't think I would use a cutting balloon either. There's not enough information, and potentially it can produce so much damage to the wall of the artery that you could get a response to injury effect with that. So I think I would go, if the vessel's 6
balloon, coronary
6 millimeters, I think I would go with a 6 millimeter balloon.
15.
I think trying to go with a 15 millimeter non-compliant balloon would be a very good next step.
That's exactly what we're doing here, George.
In order to be able to go higher pressure. One of the keys of breaking this band is number one, size. Well, we try that, and it looks like that didn't work. So we have to go force. If you go force, you have to control the force in that you don't exert unduly high forces in the normal segments around the lesion, which is what's happening in the peripheral non-compliant balloons, etc.
Right.
So a coronary balloon 5.0 would be the best solution here, and a
George,
little longer would be great.
And George, you read our mind, because one of the things we've learned from our coronary experience with everybody here, especially Dr. Sharma, is that, you know, this dumbbell shaping of the balloon is a very, very important clue in terms of how that vessel is reacting. Because usually when you start dumbbelling, it really, really means that you're exerting a lot of pressure outside on the normal vessel, which leads to the chance of rupture. So what we've stopped doing there is, especially in a semi-compliant balloon, is to stop when we start getting a dumbbell shape such as this that you see in angiographically. And I think that's a very important clue for interventionalists out there to really, really be careful of that. Not just to crank it up, not just to go blindly.
Yeah, just to explain that from, if you just keep the, don't go on fluoro for a moment.
Sure.
If you just can see this balloon with a dent in the middle, and you're not pleased by that, and this, if you keep going higher atmosphere, essentially, what will happen is that the peripheral bigger parts are going to keep growing bigger because the balloon is going to grow there, but it just, the non-compliant balloon may not have that force to actually expand the middle. So although you're going crazy high atmospheres, you're really not doing anything in the area you want, and you're experiencing problems in the areas before and after it, which can lead to rupture. And as we saw by IVUS, this vessel is truly small at the culprit point. It is not that the vessel is big and there is plaque. The entire vessel is constricted by this band.
So I mean, what we're doing now is going with a non-compliant balloon, and you know, I'm going to let the wire go forward slightly. Dr. Wiley's just going to, okay, now hold it, please, Jose. Okay. So we're just going to hold it now. Obviously, it's a team effort. It's very, very important to have somebody you trust with you to be able to work, and obviously, I'm fortunate to have two world experts outside to really help me with this particular case. But clearly, good technique always helps. And here, obviously, you don't want to have anything going on with your balloon. So we're just going to take a little bit of a test here just to make sure we're in the right spot, okay, which I think we are, and we are. I'm going to pull back slightly. Now we're going to go up here. Dr. Wiley's going to go up slowly again to prevent watermelon seeding of the balloon, and it may happen.
We're at 2.
Well, I don't want you guys to get frustrated. Down, down. So I think the band is more proximal here, so I'm going to pull it back a little bit. Go up here, Dr. Wiley.
We're at 1.
So again, learn from how the balloon expands, and you can see, there you go.
4.
Uh-huh.
6.
6, 8,
Looks like we've grabbed
10,
it, and
10,
you see how much more
12,
controlled
12.
the inflation is. There's not that much of a
14.
difference between the smaller area and the bigger reference area. This balloon doesn't expand
16.
exceedingly proximal and distal. You just try to
18.
exert as much force as you can in the middle.
He's having a little bit of pain. We're at 18 atmospheres now,
Coming down.
and we're coming down a little bit. Again, we have to respect the fact that when patients have pain, it's impending rupture. We're going to go up again. Obviously, you know, even with a non-compliant balloon, it shows how tough these lesions can be. And sometimes
I would keep it up for some time, PK,
Yep.
regardless of the pressure. You just want to make sure in this lesion
down.
the pressure is transmitted well.
I'm just going to pull back a little bit more here.
Yeah.
I think we're a little distal. I'm
Yeah.
going to come back now. Try again, Jose.
We're at 2. 4.
And the key to not slipping is exactly what you see now, that they're going, starting very slow. If you have a balloon like this and you just go straight away to 8 or 10, it's going to slip for sure. You have to go up gradually in order to not allow the pressure change to move the balloon due to disproportionate expansion, proximal or distal.
So he's having a little bit of discomfort. We're at 18 atmospheres. We left it up for a little while. We dropped it now, and now we're going to check the pressure again. Is it better now? Okay, it's a lot better. So again, it's very important to have good nursing and a good communication with your patient. So here we've done it again. We've spoken to the patient. We know, and you can see how it looks angiographic. I'm going to have Dr. Wiley just give a little test. Sometimes you have a little microperforation that you can balloon seal if you have it. You have the balloon right there. A little test, Dr. Wiley. So you can see there's no issues there. So now I'm okay to pull this balloon back. So now I'm really faced with kind of a problem here. You know, I've gone up quite high with this non-compliant balloon. I went up to 20 atmospheres with this balloon, which is a 5-millimeter balloon. Guy had pain at 20 atmospheres. The gentleman had pain with 20 atmospheres. So now the issue becomes what is our stopping point, or are we going to stent? Obviously, I'm a little apprehensive about stenting this because, as we learned in the coronaries, especially, an unexpanded stent is clearly not a good stent. So we don't want to have to struggle in expanding the stent as well. So that's going to be another issue that we need to think about. So we're going to ask our team to attach again for pressure wire to show us the pressure again.
And I mean, the pressure is going to be great. It was 3 before, it probably 0, it doesn't matter. But I think we're good to get it, and I would get the IVUS ready here in order to get another modality to understand exactly what has happened to this lesion. But it looks much more stable right now, the stenosis.
Okay, let's get an IVUS. The pressure wire, you're right, George, shows no difference. So now we're going to go ahead and get an IVUS. Let's get the IVUS ready, guys. Go in with the IVUS and show how it looks. and then we can make a clinical decision on based on what we should do here.
So if this doesn't look perfect, which to me it doesn't right now, then there's a good chance you'll get remodeling late. So if you bring this patient back in a week and do an ultrasound, it wouldn't be unusual to have still elevated velocities in that area. So that's the reason why, generally, if it's safe, the best approach is to try to make it as perfect as you can make it, as opposed to carotid stenting where you don't care whether it's perfect. In FMD, you want it to be, you know, with no stenosis at all.
So Jeff, should we do what is it called, a cutting balloon here now? I know that it's not something that we favor, but in this particular case, with that lack of expansion with a high pressure balloon at 20 atmospheres, with a scoring balloon, not so much a cutting balloon, which is an angioscope, different kind of mechanism where you have you know, a nitinol wrapped around the balloon rather than just like two knives that expand with the Boston balloon.
Yeah,
Whether that would be something here that we could try, meaning with the full knowledge that if we do mess this up, that we are going to stent. I mean, accepting the fact that, hey, you know, we need to get a good result and then stent. So that's the other option here. But let me do the IVUS here. So the IVUS is distal. I'm just going to pull it back slowly.
And you see again the lumen is about a 6.0. There's no plaque whatsoever. Now we have the bifurcation coming up from like 9 o'clock.
Now
and another bifurcation coming up from like 11 o'clock. And now this is a distal artery, and you see the gradual, there's a gradual return, and there is a suspicion of a dissection over there. Actually, not a suspicion, there is a dissection at that location, and the vessel continues to be becoming smaller with a disrupted lumen, and coming up proximally looks normal. So, I mean, there you go. I think the IVUS was incredibly helpful.
Yep.
We found out that there is no issue for perforation, and we found out that there's quite a bit of dissection. That's why it actually gave me this impression that the lesion is much more stable, because it wasn't any longer as focal. The lesion had a more extended angiographic appearance, and as you see now, this is a double lumen. The true lumen is between a 3.6, and behind there on the left side, can you please trace this area? Is a false lumen,
ACT, please.
you know, which is like a semi-crescent between 7 o'clock and 1 o'clock. And you see all this area coming up like this, and all around until, yeah, this area and a little bit higher until like 1 o'clock. And this area higher, the other way. Yeah, great. It doesn't exactly extend all the way to 3 o'clock. It kind of stops about 12 o'clock or so, but you get the idea.
But I mean, in this particular case, I mean, we do know that we're also going to disrupt these bands. We're going to have this. So now the options become simple. I mean, are we going to go ahead, expand this lesion with a 5 millimeter cutting balloon or a 6 millimeter a balloon, and then go ahead with the idea that we are going to stent it? And if we are going to stent it, do we go with a 4 millimeter drug-eluting stent, expand it out to a 5 because he's 19 years old? Are we going to use a regular stent in this particular case? And I think these are where really the judgment comes in, and I think we need to come to a consensus with who we have available, and it shows the complexity of this particular patient. Jeff, what are your thoughts on where we are now, and what you're thinking in terms of whether we go with a higher balloon? Obviously a cutting balloon you're not crazy about, which I think is right, especially since there is not much data with it. And the question becomes is whether you think we should just go stent this and be done with it, and then move forward.
Yeah, I agree. I think you should go with a larger balloon and stent it. I would not use a drug-eluting stent here. I think if you stent the artery to the size of the artery, there's a reasonable chance that you'll have a durable, excellent response. If you get restenosis in this particular lesion, you haven't burned your bridges, because there's still the opportunity, if you can't handle an endovascularly, there's still the opportunity to surgically take care of this.
Yep.
And
so,
I think
6 millimeter 15 balloon.
I think we have a good result so far. I would just go ahead with the stenting, PK.
Well, you know what I'm going to do, George? I'm going to go with a 6 millimeter 15 semi-compliant balloon here. I'm going to just go ahead and expand it to the point where I can. And then, and obviously we know the vessel is a 6 millimeter vessel. We're gonna place a 6 millimeter stent in this vessel. We have IVUS sizing both distally and proximally. Place a 6 millimeter by 18 stent. and then be done with it. And then I'm sure at that stage we are going to relieve the gradient, and we've done the best we possibly can for this to see how it does. I just feel uncomfortable, George, with our coronary knowledge, especially with a really unexpanded lesion, to put a stent in and then go high pressure. So I'm going to try to get this up to a 6 millimeter, obviously as slowly as I can, and then go ahead and go with the stent just to see how it works.
So PK chooses to go with a 6 balloon and then stent with a 6 stent. And the alternative approach might have been to go with a 5/18 balloon and then use a 5/18 stent and then use a 6 balloon to post-dilate it.
Which we could actually. We have not done either or here, George. I think we could open a 5.5. We have 5.5 stents. We can open a 5.5 stent and then do that. And again, be very judiciously careful of your wire there. So we can always go with a 5.5 stent here and then post-dilate it to a 6, which is no issues. Now again, I'm going to be careful because I know this thing has a tendency to slide forward. I'm going to ask Dr. Weiler to just give me a little bit of dye here. So I want to make sure I'm not going too far deep with this balloon.
Hey.
Just a little squirt just for me to see. And you can see here we're probably right where we should be. So we're going to go up with this balloon here. Go up, guys.
Yeah, I would be careful going distally because one technical part we don't want here is a disruption of the distal part, an extension of the dissection involving the bifurcation.
Exactly.
That would be not something we don't want.
So you can see here how it kicked me back with a bigger balloon, showing the nature of this process. Good, you got it. Oh, okay, go. Now Elizabeth is next to him, checking him on how he's feeling with pain. Just go to nominal, please.
We're nominal.
Okay, go up again.
Came down, going up again.
Going up one more time to 6. He's having a little bit of pain. And actually, it's expanded a little bit better proximally. 7, 8.
We're on 8.
So I'm just going to go up to 8 millimeters, trying to crack it the best I can. Leave it up at 8 for a little bit and play with it the way we do normally. And we're not succeeding.
Yeah, this shows you how strong how strong these fiber spans are in intimal fibroplasia. In medial fibroplasia, you don't run into this problem, but with intimal disease, this is not uncommon.
A little picture. So Jeff, we're just going to take a little picture here post. Make sure we haven't created any major issues, which we clearly haven't. So we're going to walk this out now, George. I mean, with our knowledge in the coronaries. Are you worried about putting a 6 millimeter stent here, George, and not being able to expand it? Or are you just going to bite the bullet and post still high pressure within the stent to expand it?
What I would say is let's take a picture with a nitro. Let's give some nitro, take a good picture, and then we decide if we go with a 5.0 or with a 5.5 stent. I would not put a 6.0 stent here. The 6.0 balloon barely was inflated appropriately only in the proximal part. So I don't want to create a distal dissection. If you put an 18 stent, you have enough space inside it to post-dilate as much as you want with a high pressure balloon at high atmospheres, and 15 millimeter balloon is going to fit nicely within an 18 millimeter stent. I wouldn't go crazy with a 6.0 stent.
I agree. I mean, I'm conservative as well, but we know from our renal data very, very clearly with renal stenting, it clearly is one-to-one sizing that makes the difference. One-to-one sizing is where you are going to get the bang for your buck with reduction in restenosis and obviously, the patency that we desire. We're getting some nitro together here for you to give it, and then we're going to go ahead and take a picture. Obviously, we've IVUS sized it at 6, so we're confident that it's 6 both proximally and distally. So at this stage right now, we're going to go ahead and give a little bit of nitro and see how this vessel looks post-nitro. Obviously, we've manipulated it multiple times. Now, our ACT is cooking again. It stopped at 269, so I'm going to ask Elizabeth to give another 1,000 of heparin, Liz. I'm really uncomfortable keeping the ACT below 280 in these kind of cases. So, I prefer there's going to be, I anticipate it to be a longer case. So I'm going to go ahead and give a little bit more heparin here, and then I'm going to give my nitro within the vessel there. So the nitro went into the vessel. So now what we're going to do is just flush it through with some saline. I'm going to flush it through with some saline nicely. Okay, our pressure's been rock solid stable, so Now we'll just take a nice picture. Obviously, it's a more nitro picture than anything. Can I have DSA, please?
PK, could you move the camera a little bit so we can see also the renal parenchyma a little bit on the left side and appreciate the full perfusion of the kidney? Yeah, that'd be great.
Okay, ready? Sir, take a deep breath in. Let it all the way out. And now just don't breathe, my friend. So you can see there the kidney lights up. We had this picture earlier, so stop breathing. Breathe normally. So now you can see here we've got this lesion. We don't have a dissection or perforation. Now I think we're, like we all have discussed, we're going to go with a stent. I mean, we've got a 6 millimeter stent, and I'm going to go with a 5.5 and then post-dilate it up to a 6. What do you think, Jose?
I don't know. I was thinking going with a 6.0 stent
and just keep it a
keep it there 1-to-1.
I don't think you're wrong either way.
Yeah.
So give us a 6.0 18 stent, guys.
It looks to me like the lesion is extended a little bit towards the bifurcation. What do you guys think?
I agree, Jeff. I think it's the manipulation that we've had. And I think, you obviously have some dissections there and everything. And I think at this stage here, we still have a nice zone where we can land that stent. So I think
exactly. I mean, by IVUS we showed the dissections longitudinal, and I think it's important to nail the stent before the bifurcation. Taking a long stent is a good idea. If you don't go crazy high pressure, a 6.0 stent may still be very good because you're going to nail it proximal and distally. You're going to be a little bit low maybe inside, and you can go with a higher pressure balloon in the middle.
Now for everybody who's watching, I mean, we just to tell you our thought process, we went with a 7.0 guide, so this way we have access to a 7.0 Joe Med, God forbid, if we need to put a covered stent for a perforation, we're ready. So, it's important to think of what can happen. I mean, nobody wants anything to happen, and nobody, is expecting it to happen. But that's why there are complications. Things can happen. You need to be prepared for your patient and for your the good outcome that you want. So now we're across now. We're going to give a little bit of dye. We may need to go with a bigger stent. We might have undersized it. So we're just going to give a little bit of a dye here.
Even a longer stent.
No, actually we're pretty good here.
We've got to take a good picture and have a whole spread.
Okay, now, sir, take a deep breath in. Let it all the way out now. All the way out. Now don't breathe, don't breathe, don't breathe. Okay, so you can see here, breathe normally.
Most important thing is to nail the distal.
I agree.
And then if you want to add something proximal, we can see later. But at least you nail the
well,
distal
I think
away
George,
from the bifurcation.
I think, George, in this case, we have a 23 available. I'm going to get a 23 because I think with a 23 or 24, whatever it is, we can nail it.
What stent is this one?
This is the Abbott stent. Do we have one, guys? We don't have a 6.0. 18 is the longest? Okay. So 18 is the longest, so we're going to go forward then.
This Herculane.
It's our Herculane.
Yeah, Herculane comes into
It does come in a 24. I guess we don't have it. It's such a rare size that we use.
It is indeed rare, 24. Yeah.
So we're going to go forward with this again.
And you see how important it is.
Put it on coronary, guys.
This case that the delivery of the stent is very easy. Remember that this is not a typical renal case. You will need more support with a guide and better position in order to deliver the stent in the atherosclerotic renal artery. Let me make that
now we're going to take one more picture.
For
Hold your
viewers.
breath, sir. Go ahead. Now I'm doing this on the coronary to show that we're definitely distal. I think we're perfect proximal. We're going to go up, breathe normally. Go up.
Going up.
Slowly.
We're at 2, 4, 6.
What's nominal, guys?
We'll grab it.
8. Good. 8 is nominal.
I think we're definitely covering all the disrupted areas, which is also a very important job for the stent.
Give me a 5.0 postal balloon, please, or a 5.5. Do we have a 5.5, Rick? We don't. Give me a 5.0 again.
Well, can we use the one?
I want the same one.
Can we use the same one we
dye,
tried?
please? Now I'm going to leave the balloon there. Just inject a little dye to make sure how it looks. Okay, things are looking okay. So I'm feeling very confident to take this out. Now I'm going to go ahead and get a nice injection. Hold your breath, sir. Go ahead. Good. Breathe normally. So you can see here, as Dr. Olin clearly said, you want to be 1-to-1 with your size. And you see you're 1-to-1 distally 1-to-1 proximally. So now you've got that dent, again, as Dr. Olin clearly said, how fibrotic and how tough these lesions are. So now I'm okay with being aggressive. For instance, in this particular case, you know, putting an angioscope balloon here with the scoring elements and really trying to push it open may be something that I would try to do here to post-dilate under really, really high pressures. But at the same time, I may just go with, right now at this stage, I'm going with the 5.0 post-tilt balloon, and we're really going to go high pressure at this stage. One thing, you wiped it down? Well, one thing we've learned with the coronaries is that sometimes putting the stent in will increase the pressure points within the vessel wall, which will then allow us to go ahead and exert more pressure in that particular area to crack that band. So this particular lesion, we know that we could not expand it the other way. So now we're going to go with do we have a smaller post-tilt or just a 15? Do we have an 8? We do have an 8, so we're going to wait for an 8. We have 10 minutes left, so hopefully we're going to hit it with an 8mm post-tilt balloon. Ray, can you check an ACT? We're going to hit it with an 8mm post-tilt balloon, really focus our pressure on that particular area, and really, really try to expand this to the best of our ability. Can I have the 8 quickly, please? So we're also now, again, you know, not forgetting while we're involved with the case to follow our discipline. We want to make sure that the ACT is good. We want to make sure that our guide wire is in the right spot. You know, so all those little things are happening even though we're discussing this very, very complex situation. So Dr. Wiley's loading on here, so we're going to go ahead. I'm going to try to mag up really high for you to see it and just put it within my stent and hopefully within that area of that fibrous band. It's very frustrating, and you can see why. Yeah, I got it. You can see why he did not succeed the last time in the other area. So we're going to go ahead. Okay, rail, please. Pull rail.
Okay. I think that's pretty obvious. If we're having trouble expanding this with a 5.0 high pressure balloon, you can understand the previous intervention with a 4 and 4.5 balloons would clearly be limited by the recoil of the lesion that essentially was you know, entertained here. If you can angulate just a bit so we can get the stent dent outside of the spine, might be a little bit better for the viewers in the internet. If you can go a little bit LAO to get that, the stent off the spine, just a
we will,
little
George.
bit.
We'll do that right now. We're going a little LAO. And now I want you to mag up on the stent, please.
That's good. That's
mag
good.
up, like really high, guys.
Exactly. So that the viewers can see that is an important part.
Now it's important again to follow your discipline and have both the guide and the wire, distal wire within our picture.
Very
so
good.
Now you know, you see how the balloon is right across. You're within the stent, so you can really, really go high pressure now.
We're going
so
up.
Dr. Wiley's going to go up.
2, 4,
6, 8.
6.
Good. So you see how we're
10,
exactly
12,
at the
14,
desired spot.
18,
18, 20.
I would stay there. I would stay there a long time.
26.
I would stay there for 50 seconds if you can.
So he's having a lot of pain. We're at 22 atmospheres.
20.
And
I would just keep it there for a little
and we're
bit.
going to keep it there for a little bit. He's having pain. Hang in there, sir. I know it's bothering you. And you can see we're not outside the stent by any means.
No.
And you still have a little bit of a dent. We're going to maybe go down and go up one more time down here. So we'll give him a little relief of pain, reduce our renal ischemic time.
Going up.
No. Let it go down.
It may be my impression, but I think the dent went down a little bit.
I think it did. We're going to pull back a little bit here, George. Go up again.
Fully expanded.
Going 2, 4, 6,
8,
8, 10,
10, 12,
14, 16,
or even
18,
stent
20, 24.
I would stay. I would stay longer.
I know he's
The
having
high pressure balloons,
pulling it,
if
you're
you
pulling
stay
it.
longer, they do a better job. Although I think we're going to again be
ACT?
somewhat limited.
This is a non-compliant, right?
So there's a non-compliant 5mm balloon at 24 atmospheres. Again, you know, Dr. Dangos, I mean, this brings up a nice point in our peripheral practices. You know, non-compliant 014 balloons are not made in the periphery. And it's a real problem. You know, we translate a lot of the coronary equipment into the peripheral space, and we're not able to obviously have a 6mm non-compliant balloon down.
Yeah. Okay.
No, but we do have an 035 balloon which I'm not going to stick in the kidney. I refuse to do that. I know that they have done, I know Dr. Sauce, I know where I trained with Dr. Backrack, we have done 035 systems, but I can tell you that, it's not, I don't think it's a wise thing to do in today's day and age. Can we take a nice picture, please? I'm just going to hold it here to just make sure that nothing happens. DSA, guys?
Or you can try and see if the 035 stent tracks over the 014 wire, but it may not.
Go ahead, inject. So we took a little picture just to make sure there's no perforation, there's nothing going on. The only other point here is whether we go with an angiosculpt, a 6.0 angiosculpt. I really don't think it's going to make much of a difference.
No, I don't think at this stage inside the stent, I don't know it's going to make any difference. I will probably do another IVUS and be prepared to call it a day.
You want to take a picture with him?
Hey, PK, it'd be a good idea to get a duplex as a baseline to see where you're at so you can follow the patient going forward.
Well, we do know, Jeff, like you said, the pressure wire worked. We don't have a resting gradient. We're worried about the remodeling, like you said, that's going to cause this to close later on. But hopefully we've stemmed that tide with the stent. The only issue here is obviously the unexpanded or the expansion of the stent is not the best. Hold on, I've got a little trouble getting this wire out. So I mean, this balloon out, it's very sticky. So now we take it out. And now we're going to prep up, and I want to go ahead and get the IVUS ready, guys. Sir,
Yeah.
take a deep breath in.
Let's give it a little nitro and all these things.
Go to a little regular mech. Let it all the way out, sir. Okay.
Yeah, I gotta wet this wire.
Okay. Don't breathe and don't move. Ready, Jose, to inject?
Okay. Hold your breath.
He's holding it. Inject. All right. Obviously, that's most of it is outside. I'm going to try to get this guide better engaged. Okay. Okay. One more time, sir. Hold your breath. Go ahead.
I think it looks pretty good.
It does look good. I mean, it's one of those things where it's very frustrating for what we've been trying to accomplish together as a team here. Breathe normally, sir.
I think we have a residual between 0 and 10%. So
Well-
I don't know. Before we had a residual on around 20, 25%. I think we reduced that to just about 10%. So I think it's an excellent result.
I agree with you, George. I mean, but as always, in Mount Sinai, under Dr. Olin's guidance, we want to be perfect. So it's one of those things where you're kind of stuck here. You've done the best you can. You've done everything you possibly can with this particular lesion, with the exception of cutting it. That could be possibly the only thing that we could have done different is try to use a scoring balloon, which we did not do. We chose not to do because of lack of data here. But the 035 system, I don't believe will be a right thing here because it's too distal. And now here goes the IVUS into the vessel. I'm just going to place it right at the level, right distal. And you can see the image, George. You can see the stent.
Yeah, this is a stent, as you see, these bright areas outside. The lumen now is red. The catheter in the middle is black, and you see around there the struts. And now we're, I think, just distal to the struts we're going.
No, we're still in the
We're
stent.
still in the stent.
And you can see this is the area that's not as well expanded.
And this
And
now
then-
it's a 1.
And now
2,
it's 1-to-1.
Yeah.
So it's that exact area with the band. But I mean, what's our lumen in the non-expanded area, guys?
I thought it was about a 4.5 diameter.
Okay, let's see.
Now let's see what the IVUS measurement is.
So we've got about 2 minutes left, about a 3.5
3.5,
by
that's it.
3.2. So, we've got a 50% reduction. I mean, this is the worry now. You're kind of stuck in this particular area. The only other thing I think what we could do is exactly what Dr. Olin suggested, is to go ahead and get a ultrasound prior to discharge, which we are going to do in this particular patient, and then go ahead and in the future bring him back, survey him closely. If we see that either his hypertension is going up or the stent is restenosing, then I guess consider further options. Jeff, I'm wondering if he does restenose, what would the other options be for him surgically versus going back percutaneously?
Yeah, I think I'd go back percutaneously another time and see if you might be able to pop the fibers at that time. This shows you how critical it is to get IVUS during these cases. I mean, you just can't gauge your therapy without it because the angiogram looks much, much better than the IVUS looks.
Yeah, the other aspect is that, let's remember the last time they dilated this to 4.5. However, they were limited by the recoil. At least right now we know for sure there will be no recoil. We may be around the same areas, but there will be no recoil
Absolutely.
because of the stent.
Absolutely.
Now, yes, we have possible intimal hyperplasia, which we can deal with that. The question that I'd like to ask Jeff is, what is the chances for intimal fibroplasia now to happen at a different part of the renal artery, proximally or distally? Does it happen that you treat it in one spot and then it can appear in another, or no?
What you see is what you get, and if something occurs in another part of this artery, it's probably due to a response to injury from everything that was done today.
Got it.
But I don't think you'll get new disease.
Good, and essentially the treatment for that would be aspirin and Plavix for a month. Is that, I mean, aspirin forever and Plavix for a month? Is that your idea, PK?
Yeah, I mean, you know, this is actually an interesting problem here. I mean, having this, it's a bare metal stent. We know they endothelialize a lot quicker, you know, than drug-eluting stents. So, you know, I would, in this particular case, probably keep them on a longer duration of Plavix without much data, obviously to support what I'm saying. But I think just intuitively try to keep them on a longer duration of antiplatelet therapy. But I think the important thing here is to really follow with somebody like Dr. Olin. I think it's very, very important to really have good follow-up. You know, make sure that you know, this stent may be enough. I mean, we've seen suboptimal results sometimes, even though as hard as we try, you know, to actually do very well clinically. So, but I think the key here for this gentleman, and I'm going to stress to him as a young man, is to really follow with us here at Mount Sinai to make sure that you know, he is going to do well. I personally believe that we've achieved a very, very good result here. We know, at least physiologically, there is no gradient. We know that for sure. We're treating an anatomic lesion, and based on obviously the experience of somebody like Jeff Olin, who's taken care of thousands of these patients, we really went very, very aggressively. I know a lot of people out there would have probably stopped with just a physiologic result of actually, you know, reducing the gradient from, you know, 30 to 2 or 3 or whatever it ended up being. 30 to 3, Ray is saying. So therefore, you clearly had a physiologic benefit. And again, since we have that sustained gradient, we now have a stent that's going to prevent the recoil. So hopefully we reduce the gradient here, and now we're just going to deal with the restenosis part of it. You know, again, this is all theoretical, and I hope that you know, this works out the way we really wanted to. But I think we did a really good job. We're out of time. It's 9 o'clock. I want to thank Dr. Olin, who's taken so much time out of his schedule to really spend an hour with us and really help us in this particular case. Obviously, you, George, for all your advice and your help and your encouragement during this case. And the team, more importantly, everybody here, including the people from Volcano who were kind enough to come and really help us you know, with our measurements and things like that, because normally we're scrubbing in and out while we're doing these cases. You know, I again want to remind everybody to please you know, watch Dr. Olin's lecture. I think it's something that it really is important in terms of understanding this disease beyond just the interventional perspective, what it means in other parts of your body, et cetera, et cetera. And also he's obviously going to give us some updates on what are the options for management. Again, appreciate you guys logging in. We look forward to seeing you next week. And George, I'll let you do the final.
Great. Thank you, PK, and congratulations for the great job for the entire team, Dr. Krishnan, Dr. Wiley, and Dr. Olin in the in-cath lab moderator position. This was an extremely complex case, accomplished very, very well with an excellent result. In my opinion, it will be durable, and we'll give you a follow-up, and you can follow this case and how it will go in our website, www.peripheral interventions.org. And if you have any final comments, or if you'd like us to respond to anything, please email at the email address info@peripheral-interventions.org. And we'll see you again next time, October 24th, same time as today.